So welcome to BedEd's presentation of Rapid Response Avoiding Failure to Rescue. My name is Michael Nanney. I'm one of the speakers with BedEd seminars. This slide deck or presentation is about rapid response teams in today's healthcare environment. I've been working now for over 30 years as a registered nurse. I work in a phase 1 recovery room, and sometimes just picking up those little red flags can make all the difference, and we're going to sort of be talking about that today. Rapid response teams have now been around for a while. This presentation is not just for nurses with rapid response. This is a great slide deck, I think, that we've put together, even for nurses on med-surg floors and telemetry units, maybe even a step-down unit or a progressive care unit. Nurses will learn, or as you start watching this, you can start learning to pick up on small little clues and how you can start taking care of your patient that has started to deteriorate or where you have noticed that they are deteriorating. This is also a great slide presentation that can show you and be explained to you how you can also help the rapid response team or medical emergency teams in your system. So here's some course objectives. We will be talking about a little bit about what brought rapid response teams on. When do you call them? How do you call them? Who do you call? Is some information that we'll be giving. How to perform a rapid assessment. How to identify those little red flags the patient's trying to give to you, those early warning signs that will make you investigate even further. And we will get into other assessments as well. So back in about the mid-1990s, there was a group of physicians that was worldwide. It was just not the United States. And they wanted to know, or sort of the question that they ask is, what happens in the first hour or several hours before a patient starts experiencing a cardiopulmonary emergency? What is the patient doing? In addition, as I've got up there, is how do we intervene and slow down the deterioration? In other words, how do I recognize it and get it so that the patient does not progress even more? Let's sort of stop the madness there. In addition, one of the things that was shown in the studies is that there were several hours that occurred where the patient became hemodynamically unstable, or there were those little clues that staff was just not picking up on, especially on general floors. And as the statement up there, it's not that the patient became suddenly ill or started having deterioration. It's just that we all of a sudden realize, hey, this patient is not doing well. So they wanted staff to be able to learn to pick up those clues, but also to be so-called empowered to call. And you know, if we recognize things early, then we can intervene early and we have better outcomes. And we've known that now for many years through evidence-based practice. So the outcomes from that big meeting from United Kingdom physicians, physicians from Australia, physicians from the United States, they wanted to improve patient safety and the quality of care that we provide. Well, all nurses definitely want to do that. The Institute of Healthcare included rapid response teams and improving patient care in their 100,000 Lives campaign. This has also been sort of supported and taken under the wing of our Joint Commission here in the United States. Part of when they put out their national patient safety goals, one of those years they put out, and they were saying the hospitals should have some type of rapid response team or medical emergency team or response team within the system. By doing that, nurses had somebody that they could call to say, hey, my patient just does not look right. My patient's starting to do this, and we intervene faster. The whole point really was to implement and utilize rapid response teams, and therefore not having to call the code blue teams as often. There's two big differences in those teams and their duties. We wanted to know about the patient's changes, both cardiac and respiratory. How do we prevent patients from going into a code blue status, going into cardiopulmonary arrest? And how do we get patients, if we have to move them to the ICU, a little bit more stable, we're a little bit more in control? Or can we intervene to keep the patient from having to move to a critical care unit? Other things too was to improve those outcomes, as we talked about, improve satisfaction scores. Now, whose satisfaction scores? One, definitely the staff. When staff has patients that deteriorate, not do well, they have to be transferred to the intensive care unit. That does not help with satisfaction scores on the staff level, the patient's level, even the family's level. Also, if we've got a patient that needs to go to a critical care unit and we can intervene quicker and make them more stable, they're going to have a decreased length of stay. When we have to have patients admitted to the ICU, that can add anywhere from $7,000 to $10,000 per day of care that was really unexpected. So the other additional findings that were done in the research after all these physicians met is, one, patients can start presenting signs or giving you clues basically up to 8 hours prior to their event where you're like, okay, something is going on here. They said 70% of patients experience some type of circulatory problem. Now, that could just be simply some hypotension, weak, thready pulse. They could just look pale. The patient just does not feel well. 84% of patients who develop cardiac arrest have been unstable probably 8 hours prior to experiencing that cardiac arrest. So we missed this wonderful opportunity to prevent that patient from going into cardiac arrest. Now, sometimes it's just inevitable. We could be standing right there already intervening. The patient is going to go into cardiac arrest. If they do, we know what to do with those patients. So rapid response teams are founded on the concept of failure to rescue. Now, that doesn't mean we were sitting back and not doing our job. Sometimes we just don't recognize those little clues those patients are giving us. Sometimes we just don't know what to look for. And hopefully that's what this presentation is going to be all about, is to help you, give you the tools to your little toolbox, to your tool belt, your arsenal of equipment that you take work with you, maybe information to add to your little mental Rolodex. So the whole thing is that we want to talk about early assessment. How do we intervene and detect that all really quickly, so therefore we can improve our outcomes and survival rates, and therefore we increase satisfaction scores. So some of the issues that were found that needed to be addressed was, one, again, was that failure to recognize those early signs and symptoms. What does a patient look like that could be having a pulmonary embolus? What does a patient look like that has developed or is slowly developing a pneumothorax? The other thing too is some people don't understand that process of what is the assessment, what are my treatment plans, what can I do now, and what's sort of the goal of all of this. The other things too was a communication issue. Who do I call? When do I call? And those that work the off shifts, the weekend shifts, sometimes you know how difficult it is to get in touch with a physician, especially a primary physician. If you have a group that's a hospitalist group, it's like, well, I'm going off, this one's on call, you need to call that. That all wastes time. There's a breakdown in communication. Are we talking the lingo and doing the walk between nurse to nurse? That could be the floor nurse having communication with the charge nurse, or another fellow nurse saying, hey, my patient is doing this, come look, what do you think? Is that information truly being handed off to that to understand that there is some urgency with my patient? I sort of like need you now. The other is having communication between the nurse and physicians. I think we talk very differently. We use different lingo. So how do we improve that? So how do we take a situation and communicate effectively? And that's one of the other things that we're going to talk about today. There is a big communication gap. Sometimes physicians, I think, blow off nurses. Sometimes they don't understand that we are very concerned. We're looking at the patient. Can we relay that information to the advanced practice provider, being the physician, being a physician assistant. Maybe you need to call the surgeon and say, you know, but this is what I've got going on. I am very concerned with this. And making those statements and giving them, and sort of what I call painting the picture of the patient and saying, you know, I really need you to come look at this patient. So why do we need to communicate effectively? Why do I need to give you that information a certain way? Well, one, it improves efficiency. Do I have to spend time relaying it to multiple people? Do I have to sort of tell you in several different ways about what's going on with my patient? It does improve patient care. That if I can give you that information, then we can spend less time talking about it and be at bedside providing care for that patient. Also, too, when you communicate effectively, it sort of makes you a little bit empowered. You know, you're like, I know what's going on here. I'm just truly not sure what the diagnosis, but something is not right with my patient. And if I can get that across to somebody else that I need help from, you know, I could be that new nurse, or I could be a nurse up on the floor, and I need a critical care nurse to just say, I need you to come up and look at my patient. This is what's going on. Sometimes just a second pair of eyes helps tremendously. We all know what we do, but sometimes we still are learning. I think we learn every day, and having effective communication that you can get to another nurse and let's share information. What do you think about this? What if I do this? Will that help? Also promotes professionalism, and not communicating effectively can lead to errors. If I don't give you the right lab value, what if I miss a decimal point? What if I tell you something that was misinterpreted? Then that could all change the plan. I could leave off important information that you would need to know, or that I would need to know if I'm the rapid response nurse. Inaccurate information, just lab values, history, anything like that. Allergies could be very important. This not communicating effectively sort of breaks down, and we lose that continuity of care. We could miss protocols. We might miss the right procedure that we need to do, or protocol that we need to follow. And therefore, it's going to lead to errors, and it's going to delay the care that we're going to give. So I want you to look at this scenario with me. And I'll just read it out to you. Hey, this is David. I am one of the nurses. We've got this old lady here who is acting weird. Okay. So we can already see what is old, because what is old to me may not be old to you, and vice versa. Okay. And what is weird? That is a very broad term. Now, I think she can't move her right arm or something like that. So is it the right arm? Is it the left arm? What's going on? Her daughter intervenes and says, you know, she was at church yesterday. She does have a history of high blood pressure. I put in a 22 gauge IV. I've got some fluids wide open. What do you got running wide open? I drew some blood. Was that lab work? Was that a capillary blood glucose that you drew? Whatever. And she has crazy results. What's crazy? I might be concerned definitely of a potassium of 6, but somebody else say, oh, you know, she's at 3.4. Well, we don't worry so much about that potassium. Yeah, it's low, but it's really not that low to be worried about. So when we look at that, you know, what is her results? Hey, that guy's over there. You know, this is talking, you know, so now you're like, well, who are you talking to now? You've got to be very focused. So how about, I really need your help for me to get her to CT. I've got more things to do. I've not even been able to take a break yet. This is just crazy up here. So what do you want me to do? She's got a cardiac history. All that. So basically what you see, this is very jumbled. There's no organization with this. And to me, it sort of leads to this situation. I don't know what's going on. This is the thing where the cat and the dog is talking, which has totally separate communication. We've always heard that men are from Mars, women are from Venus, so that communication can be off. What we need is facts. I need you to be brief, I need you to give me the facts, or you need to share that with the rapid response nurse or whatever nurse or person you're consulting with. So how about this? Hi, this is Michael. I am one of the nurses up here on 3 West. I have a patient, she's 87 years old, and she's been here on our unit. She came in this morning with weakness. She's having difficulty moving her right arm, and now she's having slurred speech. Her daughter gave us some information, said that yesterday while they were at church, she became unsteady on her feet, but then felt better once they let her sit down. She says her mom has a history of hypertension, and that right now her heart rate is 82, her respirations are even and non-labored at 22 breaths per minute. She has good color. I have checked a capillary blood glucose level, which is at 104. I have already performed an electrocardiogram, which is now showing atrial fibrillation. I have followed my policy by calling the CT scan to get her down to do a head CT based on her presentation and our policies and procedures. Would you meet me please urgently in radiology? Okay, now I have this beautiful clear picture of this 87-year-old lady. And by everything that's being presented, yes, this woman does need to have a rapid CT scan. She needs to have the electrocardiogram. Vitals have been updated. So now we have painted a much better picture. So imagine with the situation before that I presented to you, this is where you sort of learn how to cuss. Now we know nurses can cuss, but I'm going to teach you how to cuss in a more professional manner. And cuss stands for concern, uncomfortable, and a safety issue. Take, for example, let's say someone calls you and says, I need to move my patient to your unit. The doctor's not seen him yet. I don't really have any orders, but she's being admitted because she's a little short of breath. I want to get her up there so I can get her out of my unit. I've got people coming in. Well, a statement that you could say is, I understand, but I'm very concerned that you're going to bring me a patient that has not been evaluated by an advanced practice provider, by the physician. I don't have any orders. That makes me uncomfortable, and really this is a safety issue because I'm going to be providing care for a patient I don't know anything about and I don't have any orders. And that sort of set us up right there for some failure. I like to add the additional S to help recommend sort of how to solve this problem, how to make both sides happy. One could be as soon as you get your orders and your patient admitted, how about if I send a tech down and a nurse down to help transport the patient up to relieve you of that duty? Do something, or can I call the doctor for you? So therefore you've expressed your concerns about the patient, but you're also assisting because you're showing your professionalism and you're putting the patient at the center of attention. Here is what we should be doing. The other thing too is having that closed loop communication. Basically, you're not giving a lot of these strange variables. I have an old lady, she's doing something weird, I've got crazy lab values. You're making it very simple. 87-year-old female, right arm weakness, you know, maybe some slurred speech. I've noted, I'm going to CT scan. Right there, there's no question as to what's going on with the patient. You already know there's some urgency going on with this patient because this patient's probably experiencing a stroke. So why do we have these rapid response teams? Well, one thing too is to recognize the deteriorating patient. You know something is not right with your patient, so you make that call to this team or to, let's say, the charge nurse in the critical care unit who's acting as the rapid response nurse. They can come up and help you assess and say, yes, this is what's going on. Maybe this is what you thought was going on. It's not. It's also a great opportunity for learning too. You give good feedback too. Yeah, you have picked up on this. You are exactly right. This also, the patient would also demonstrate this, or they would have this side of them. So you're learning as well. You're sharing information. And education, I call it reverse mentorship. There are young nurses that are teaching this old nurse a lot of new things all the time. So we share information. The other thing too is to work off evidence-based practice and to provide those interventions. What's appropriate? What can I do right now to make this patient better? And also rapid response teams do follow-ups. Sometimes they will definitely round. They may round 8 hours later on a patient that may have stayed on your unit or moved to another unit. They want to make sure that what we've done or what has been done by the rapid response nurse is working and the patient is improving. If they're not, why? What happened? Let's stop that now and let's assess again, what do we need to be doing differently to make this patient get on the road towards improvement and have a better outcome. So benefits of a rapid response team, one is having a backup system in place and always available. I know it's great when I can call the critical care nurse and say, hey, will you come down here? I'm going to call tonight here in the recovery room. I have this patient. His blood pressure started to be a little bit low. He's gotten a little bit more tachycardic. I just want you to come lay eyes on this patient with me as well. He's supposed to go to a med-surg floor after this femur fracture. But he's pale, he's getting a little sweaty, my blood pressure's starting to drip down. I want another pair of eyes. I also have access to experts. You know, rapid response teams are made up of not just one person. Usually they're like a charge nurse from the critical care unit, or they're a separate team. They have respiratory therapists. You may have, in large hospitals, the first-year resident or the fourth-year resident. So you've got people that can focus in on this patient. They are used to seeing this kind of patient be in this situation. So sometimes their comfort level is going to be a little bit different from yours. You can gain new knowledge. You can learn from situations. We all learn every day. Hands-on, we can learn to assess patients a little bit easier. We pick up on signs going, hey, I remember the last time I had a patient like this, they did this. This is what they're doing. Gain new skills. You might be learning how to assess, let's say someone comes up and needs to interrogate an ICD or a permanent pacemaker. You're seeing what that person is doing, and so you're just gaining new skills all the time. The other thing too is you got teamwork going on. It takes all of us to work. Sometimes, you know, I don't know the answers to everything, so I have to consult the respiratory therapist. Sometimes I pick up the phone, I'll call the pharmacist and say, hey, this is what's going on, we've got this going, what are your thoughts? So use your resources. A lot of times too, safety net. I've heard nurses, especially new graduates that are working night shift, they feel like they've got somebody they can lean on if their patient goes bad. They feel like they've got somebody that they can call. They're not going to sit up there and drown because they're trying to learn as well. It's a whole lot easier to get a hold of a rapid response nurse than sometimes physicians. That physician may call and say, no, I was only consulting, or I was the only one, I was just doing the surgery. You need to call the primary care doctor. Or if the patient has a call a cardiologist. The patient may not have a cardiologist. So you've got to figure out who to call. Well, that wastes time. You don't have time to sit there and go through a plethora of phone numbers and find out numbers have been changed, or I'm not on call but another doctor is on call. You call the rapid response nurse and let him or her come assist you with doing that. Let them follow. They're going to have policies and procedures or protocols that they can do to let's get the patient off of that unit or that area and move them to an area that is more appropriate to provide the care that that patient needs at that point in time. Believe it or not, rapid response teams help nurses stay where they are. If nurses feel like they're drowning and don't have any support system, they're going to go somewhere else. So it has been shown to improve retention rates at hospitals for new nurses. Satisfaction scores, patients love it. Families love it. A lot of times too, you'll see where the families can make a call because they are concerned about the care or what is going on with their family member or their significant other. As far as nurses are happy, so satisfaction scores go up all the way around. You know, happy patients make happy nurses provide better care, which makes happy patients. It all works in together. So the responsibilities of rapid response team, what are they supposed to do when you call them? Well, they respond to your call for help. They're there to help you evaluate and be a consult. You do it all the time. You just say, hey, come look at this patient with me, or hey, look at this drug with me. We rely on each other all the time. You will continue to do that throughout your entire nursing career. I still do it all the time. They perform proactive rounding. Maybe it was a patient that got called on in the middle of the night for some shortness of breath and so forth, but was able to stay up on the floor because they were able to give the patient a breathing treatment and institute some oxygen, start them on some bronchodilators. Maybe they needed some steroids, just whatever the situation. So they may round again on the next day to just say, hey, how is the patient doing? You've got that critical care resource from those nurses from the critical care unit, or those, and often those nurses become rapid response nurses. You also have someone that can provide you education. What if you don't know about a chest tube? They can go over that with you. They can show you a rapid way to assess that to make sure everything is fine. So you learn right there at bedside. They also collect, record, and report data. How many calls are they getting? What calls are they receiving? Are there more cardiac? Is it more respiratory? Is it for education purpose? Is it just for a consult? They look at all that. They collect this data all the time. And provide formal and informal education. Sometimes they hold classes and say, hey, do you know what to do if your patient starts having chest pain? And they could do informal education right there at bedside. So you know the difference between the two. So they're there to help you with all of that. Now, remember, rapid response teams are there to start rapidly assessing and intervene before the critical issue occurs, the code blue situation. They are supposed to intervene prior to the patient having a code blue. They are to optimize oxygenation and ventilation, and let's try to get some type of normal hemodynamics or an acceptable hemodynamics. Is my blood pressure okay? Code blues come after the patient has coded, where we now have a critical patient and we need to follow our guidelines through the American Heart Association of the Advanced Cardiovascular Life Support Protocols. Then we get that. Let's not get there. Let's use rapid response. This, we can save the patient before we get to the code blue situation. Now, bedside nurses, you've made the phone call. So this is not the time to leave. You are going to be very valuable. Bedside nurses play an important role. You are very valuable if you're one of those bedside nurses that is watching this, so that you can learn. One, you've recognized the need to make the rapid response call. You just may be concerned. You just may say, my patient is not acting the same as they were upon their admission. There are some changes. You tell them, I am Mr. Jones's primary nurse. This is why I'm calling you. He seems to be more lethargic. He is very tachypnic. I notice his oxygen saturations are dropping. Okay, he was admitted for pneumonia. He has a history of emphysema, things like that. You can help attach cardiac monitor. If they have a saline lock-in, go ahead and access that. Even if it's just simply a 250 or 500 ml bag of normal saline that's running at KVO. You can help obtain labs. It may be where you need to make that phone call. Let's get another set of vital signs. And we're going to talk about why we need to be consistently doing vital signs and the rationale behind that. You might need to be making the phone calls. We may need for you to contact the family member. We may need to say, hey, I need you to contact the surgeon. This is a surgical issue. Or I might need you to call radiology to come up and do an x-ray. Also assisting with the transfer, and that's simply what I need somebody to help me push a bed to the patient to the critical care unit, or do we need to go to radiology or somewhere else? So we're going to need that extra pair of hands. So you are invaluable during these calls because you know the patient better than anybody else. You're their primary nurse. The other duties or responsibilities of the primary nurse is give us a head-to-toe assessment. Give that rapid response team nurse, this is what I've noticed. This is how he was when he presented. These are the changes I've noted. Give me some background information. Things such as the patient was just started on blood thinners. The patient was just started on beta blockers that have not been adjusted yet. Do we need to know the patient's a no code blue? Some patients are still codes, but they don't want to be intubated. That's important to know. Also, cultural and religious beliefs. In our area, we have a melting pot. There are multiple different cultural backgrounds. We have backgrounds or cultures where male nurses are not supposed to be taking care of the female patient. The husband plays the very important role in providing information and being with that. We need to know that. Religious beliefs. Can the patient take blood or blood products? The other duties is, okay, we've gotten into a code blue situation. I need you to make that phone call. Let's get the code blue team there. Don't forget, you also have care of the family. You may need to notify them. You may say, hey, this is the rapid response team. Your father started having more shortness of breath. His SATs were dropping. I've got these nurses coming up and a respiratory therapist to evaluate so we can start making your father feel better. So, and you're giving them that information. Now, when do you notify the team? When do you need to pick up that phone and dial for the rapid response team or page or however you do it for your healthcare system? Well, one, the family comes to you and says, hey, I am concerned. And you go down and you assess your patient and you're like, yes, I can understand why you're concerned and I am too. But let's get someone up here that we can consult with to have them look at your family member as well. The patient has had an acute change in their mental status or altered level of consciousness. Now that is really one of the key words, is the acute term there. The patient suddenly has changes, and so what's going on? Why is this patient all of a sudden more confused, or is unable to follow commands, or has altered level of consciousness that earlier they were just fine? They were very alert and oriented. They understood your questions. Acute changes in hemodynamic status. You have a patient that has a wonderful blood pressure. Next time you go in and check, your patient is now 80 over something and your mean arterial pressure has dropped. You're like, so you recheck that and you recheck it in both arms and you figure out, okay, what's going on here? Why is my blood pressure low? You may even go get another Dynamap or another machine to confirm that, but that is what you're doing, because now you're concerned that your patient has a lower blood pressure or an elevated blood pressure, severely high. All of a sudden, have they developed malignant hypertension? Your patient's now having respiratory issues. Your patient is also having acute coronary syndrome signs and symptoms. They're having chest pain. They're having some weakness. They could be pale. They're tachycardic. They're dyspneic. They're tachypneic. They're pointing to their chest. So you know the patient could be doing it. And we know that acute coronary syndrome includes STEMIs, non-STEMIs, and unstable angina. Your patient is having signs and symptoms of a possible code stroke. And however you evaluate that in your system, but we will also talk about patients that have neurological acute changes. Sepsis signs and symptoms. We are very aggressive with sepsis now. We are very much educated all over this country about it. And we've instituted code sepsis protocols. So is your patient doing that? Does your patient have symptomatic hypertension? Okay, is your blood pressure up high? Now your patient is having sort of, has increase in nausea and vomiting. Are they having vision problems? Are they having weakness? Do they become unresponsive? You have a staff member, a fellow nurse, or yourself is concerned about your patient. Things have changed, but I can't put my finger on it. He does not look the same as he has come in. Something is different. He looks like he is sicker. Make that call, okay? The other two is sometimes we just call physicians, say, hey, this is what's going on. I'm concerned with the patient. I'm also uncomfortable with his situation, but we page the physician. 10 minutes later, we page that physician again, and he or she has not returned the call. Then stop wasting your time trying to call the physician. Let's call rapid response. We can get access that way, or that team can get access to other physicians to intervene or to be there to guide us in the care of that patient. So here are the specific guidelines to activate the team. Now every institution now is going to be different, okay? The one thing that's about rapid response, this is not going to be a recipe book for you, but this is going to give you some guidelines, because everybody works very differently. You know, one system versus another system may say the patient's heart rate needs to be this versus the 40, less than 40 to call. Responsibilities. So don't forget to look at what your system's guidelines are. But I'm going to give you sort of general idea. We're going to discuss some different kinds of patients, and just to help you learn from this, like I said, to gather that little bit more of information. I want to give you a little bit more tools for you to be more comfortable with rapid response in patients deteriorating. So these guidelines are out of one of the textbooks I used to help build this slide deck. So heart rates less than 40 consistently or greater than 140. Now, we all know there are patients that have heart rates in the 30s and 40s and they're normal. So don't forget to treat the patient and sometimes not treat the number, okay? A 40 heart rate on some patients is normal for them, okay? But you would have known that based on the patient's initial assessment, all right? Systolic blood pressures of less than 90 or greater than 200. Yes, we need to look at that because that's going to affect our mean arterial pressure, and that can either, that's going to affect our perfusion, or it's going to cause a problem because of being that elevated. Respiratory rate of less than 8. The patient is just not ventilating enough, or if they're too tachypnic, they're not going to stay tachypnic long because they're going to sort of wear out, become tired, and then they're going to become bradypnic. Pulse oximetry less than 90 at all times. Now, there are some patients that live at 90, that live at 88, and they could be the chronic lungers. But again, what is the baseline for your patient? You take that patient that's in for another reason, that is, let's say, just had a gallbladder removed, they've been in the high 90s, they're alert and oriented, and now for some reason we cannot get those saturations up. Acute changes in the level of consciousness, again, would be a reason. You have airway issues. Is your patient got upper GI bleed? Is your patient just constantly having active vomiting? That can interfere with the airway. You've got a patient that's become very agitated or can start having seizures greater than 10 minutes. Okay, what's going on? Is your patient in DTs, delirium tremens? Is your patient having neurological changes? So you may need it. If you have to start pulling out Narcan, and you don't get the response that you expect from the Narcan, okay, it's time to get somebody on board, because you've got to go back and think, if your patient's got respiratory depression, do they have airway issue? Are they having ventilation issues? We got to treat this because we know the cascade that's going to occur. Uncontrolled bleeding. That could be from anywhere really, but especially the airway, esophageal bleeding, anything that you think is going to interfere with the airway, we need to get some help up there. And then failure to respond to treatment. What if you have a patient that's in some mild pulmonary edema and you get orders to put the patient on O2, give them some Lasix, let's give them a little bit of an opioid such as morphine, or do we need to give them a little bit of nitroglycerin? What do we need to do to treat? And the patient is not responding, seems to be getting worse. They're going in the opposite direction. There you go. Again, you can call your rapid response or medical emergency team to get you some help. This patient may need more aggressive care. This patient may need to be moved to the critical care unit so they can get some of that one-on-one care, or that one nurse with two patients, or even two nurses to one patient. So let's get the patient stable and let's get them moved to an area to provide the most appropriate care. So I want you to look at these 5 situations, okay, and I want you to determine should rapid response be called. So the first patient's a 44-year-old male that's 2 days post-op of having a femur fracture secondary to being in a motor vehicle crash, okay, and he's using his PCA. And you go in, you check him, now stats are only 90%, but his end-tidal has risen up to 49, his respiratory rate's only 10, and he's only responding to pain. Yes, you're probably going to have to stop the PCA. The patient most likely has overdosed on it. Also, my thing with PCA is that it's supposed to be patient control, but you know families pick up that button and say, you know, I think he was having pain, I have been pushing the button. So I would, just simply because this patient now is not ventilating very well, as evidenced by his end-tidal CO2, and now his pulse ox is dropping and he's demonstrating some mild bradypnea. The female patient, 82, that was admitted for confusion and weakness, now has increased confusion. She's now disoriented and she doesn't respond to commands, and now she's having problems speaking. Okay, so she is now probably slow onset. Is this patient having a TIA? Does she have a hemorrhagic stroke? Is she having an ischemic stroke? What is going on with this patient? So this would be a classic patient also. With difficulty speaking, I could have airway issues because now I've got dysphonia. The other patient, a male patient, 69 on telemetry unit, he got admitted because he had a new onset of atrial fib. All right, and now his heart rate is 148. Well, we know that the standards now are that heart rate should be at least 110 or less. That is the new standards as far as controlling heart rates on atrial fib. But now he's 148. Is he not responding to therapy? He's also got some shortness of breath. So is this patient now developed atrial fib with rapid ventricular response that we need to treat? So obviously on this patient, yes, again, we would call the rapid response team. How about number 4? We have a female patient. She's 51 years of age. She had an appendectomy 2 hours ago. Okay, so far so good. We see this. This happens all the time. She's a little bit now sleepier. She just looks like she's wiped out. Now, that could be due to her not sleeping the night before because of pain, or maybe she had surgery in the middle of the night. She also got general anesthesia, and she's probably just wiped out. She's exhausted. We know how general anesthesia affects patients. Prior to transfer, the PACU nurse gave her 50 mics of IV fentanyl. When she gets to you, now she's snoring. She's got a respiratory rate of less than 8, and her pulse ox is 88% on 2 liters. Okay, so we could already see right now, snoring airway, a noisy airway is partially obstructed airway, or is an obstructed airway. We need to fix this. So again, what is going on with the patient? She may not be tolerating 50 mics of fentanyl, that smaller dosage, secondary, because she probably could still have some general anesthesia on board. Finally, we got a 91-year-old little lady. Family member says that mom doesn't look right, her color is very pale. So you go in such, all right, what's going on with mom? What's going on with grandma here? So this may need, I need a second pair of eyes. And this may be where you just need to call that critical care nurse or your rapid response team to have them come up and evaluate her. What is going on? How long has she been doing this? Was this an acute change? So how do we be successful? How do we really shine when we have rapid response teams? One, we use our evidence-based practice, okay? And I've got those reversed, but we'll fix that for you. So evidence-based practice, we know because we know that evidence-based practice comes from research because some nurse somewhere said, hey, what if I do this? And then the research project gets going. And then they find out, hey, this is the best way to do it. Algorithms and protocols are user-friendly for all teams. That means that if I'm working with a respiratory therapist, we know with chest pain, this is exactly what we're supposed to do. Frontline staff are empowered. That means if you are the med-surg nurse, you got a patient that doesn't look right, you are empowered. You're going to get any sort of repercussions or backslashes or anything like that because you call the ridiculous. Nobody's going to say you're wasting my time. You should never feel that. You should be truly empowered. You should be very autonomous to be able to call the rapid response team. Those rapid response team nurses that may be watching this e-learning, use it as an educational opportunity. Maybe your nurse just does not understand, or say yes and say, but I'm glad you called me, I think we're fine here, and explain what's going on. Share what's going on in your mind with maybe that new nurse or that nurse that maybe called you and this was not a case that you needed to be called. No hierarchy here. Everybody should be on the same playing field. You should never feel like you're inferior and someone should feel like they're more superior. We've all got to work together. We need that nice horizontal care going on. Everybody plays an important role, from a nurse tech that could be great at going to get a suction canister, to the administrative coordinator of nursing that is arranging for a patient to be moved out of ICU so you can move your patient to ICU. Everybody's playing a great role. So there you have teamwork is collaborative. Everybody's on the same sheet of music. Everybody knows this is our patient. Our focus is on this patient. Our goal is to provide care with this patient. Personal issues are out. Nobody should be saying, oh, I haven't been to lunch yet, or would you do this? I need to take a break. No, this is all about our patient right now. Team briefing is very important. What could we have done different? Did we follow the protocols? Was there something that the rapid response nurse missed, or the med-surg nurse missed, or something like that? You know, it's easy to do because we constantly are learning. And do you have administrative support? This should be all the way up, higher up the nursing chain of command there. Also, do you have your medical team support from physicians? Do we have a medical director that says, hey, We need a rapid response team. Here are the protocols. These are things that you as a nurse on the floor during the need for rapid response and the rapid response nurse can do without a physician being there. We can co-sign the orders after the fact. So therefore we don't delay treatments. So looking at algorithms, of course all of you are going to say, I love the one on the left. It's like the lamp doesn't work. Is it plugged in? Is the bulb turned out? Whatever, replace the bulb. Versus something on the right. Well, if this happens, do I do B, then maybe C, then I go back to B? That is very confusing. That's not easy to learn. So if you're going to build a protocol, you build something that people can easily understand and follow. I do A, I do B, I do C. And you keep it very simple, because when you get it complicated, then delay in care occurs. Or people are like, now we're having conversations because we have conflict about, I think we should do this, no, I think we should do this. It should be very specific. All team members know exactly what's going to be done next. Therefore, you can anticipate what's going on and already be prepared. Like a simple protocol, your patient starts having chest pain, you know automatically to go in, evaluate that patient, determine if it's cardiac or non-cardiac. If you think it's cardiac, you're going to do that 12 lead. You know who you're supposed to call. You're going to start following. A lot of cardiac emergency orders, standing orders on certain units would be go ahead and administer baby aspirin, go ahead and give nitroglycerin, make the phone call, obtain a chest x-ray. These are things that you can do without having to have a physician come up there and tells you directly, do this, do this. Rapid response teams are designated groups of healthcare clinicians. Okay, so you have a group of health. This is not just nurses, respiratory therapists, pharmacists. Sometimes a chaplain is involved in rapid response teams who can be assembled. That means brought together. They may be in different parts of the hospital, but all of a sudden they've come together, they've been activated to come and deliver critical care on a floor that is not a critical care unit. So therefore you've got this team that can come up there and work outside of a critical care unit but provide the care your patient needs regardless of the arena that your patient is in. They provide early recognition, so they identify the situation, they identify the problem, and they respond to that problem in a very appropriate manner based on the patient's presentation. That's what that, so relax. Rapid response teams are there. You can sort of take that deep breath. You've got all the help you've got. Rapid response nurses, you're there. You've got team support. You've got people that you can consult. And you put your respiratory therapist to work. RTs, do your thing that you've done. That's what you're trained to do. I love it when the respiratory therapist is there, because I could say, do we have an airway and are we breathing? Do we have oxygenation, ventilation? They're going to ensure that. And if it's not, they know how to take care of that. So that sort of lets you step back and survey the situation and sort of be the point man in order to delegate who needs to be doing what.